started in just a couple of minutes. I want to start on time today. We've got a very excellent agenda. I think a lot of good information. Okay. Thank you for our interpreters who are here. And I want to thank all the members of the task force and the advisory individuals again. I know this is taking a lot of time, but it's a very important issue that we are stepping through, taking care as best we can in our state of our young children and their families. So again, thank you. And we'll move forward to see if we have a quorum, first of all, through our roll call. So Mary Claire, I'll turn that over to you.
All right. Can y'all hear me? Okay. Dr. Buttress is here. Representative Richard Bennett. And if you're on Zoom, just say here. That'll help. Senator Hobb Bryan. Senator Nicole Boyd. Miss Miranda Carter. Representative Kevin Felsher. Dr. Tanya Fitz.
Here.
Miss Kay Carr, did I? Dr. Heather Hanna.
Here.
Miss Biz Harris. Dr. Carlin Hennington. Senator Chris Johnson. Miss Leslie Junkin. Dr. Sophia Leggett. Senator Tyler McCon. Representative Sam Mims. Dr. Denise Powell. Representative John Reed. Dr. Courtney Walker.
Here.
Mr. Keith Van Cannon.
Here.
And then we'll also introduce our advisors. We have Dr. Julie Parker.
Here.
Dr. Kenya Wolf. Miss Penny Manzel.
Here.
Dr. Catherine Cassidy.
Here.
Dr. LaShonda Carson. Dr. Candace Carter Stevens.
Here.
Dr. William Brown. And Miss Sarah Myers.
Here.
And then we also have some guest presenters with us today from the U.S. Department of Education, Miss Kate Moran, Mr. Matthew Schneer.
Here.
Hello.
And Miss Kayla Supranet. I'm sorry if I messed up your name.
Kala is not able to join today, unfortunately.
Okay. And then we also have from the Center for Mississippi Health Policy, Mr. Mitch Adcock.
Here.
And Dr. Larry Smith.
Here.
And then also, we just want to thank our interpreters, Linda Robertson and Francis Woodard. And we do not have a quorum.
We do not have a quorum. As others come in, if they do, which they may around noon, because we know people do have other jobs, then if we can maybe come back to the approval of the minutes, that would be great. But we'll go ahead and move forward because we do have a lot to cover, and we're plan to end at 1 o'clock for everyone.
Elizabeth Harris is here. I apologize. I just missed my name by like one person, I think.
Thank you, Viv.
And Chris Johnson.
Kevin Felcher is also present.
Oh, Kevin Felcher, we have a quorum. Okay, excellent, excellent. Thank you.
Miranda Carter is also present. I believe I missed my name.
Perfect. Thank you.
Thank you. Thank you.
Okay, then, let's go to item number 3. Let's, first, I'd like for a motion to approve the June 1 minutes. And we'll need a motion and a second, please, if you've read them.
Elizabeth Harris motions
Okay.
to approve the minutes.
Elizabeth Harris moved to approve the minutes. Do I have a second?
I second. This is Courtney Walker.
Second. Okay, thank you, Dr. Walker. Now let's go to a motion to approve the July 24th minutes. Do I have a,
Tanya Fitz, motion to approve the minutes.
thank you, Dr. Fitz. Is there a second?
I
Oh.
second Heather Hannah.
Oh, we have
Too.
and Dr. Hannah, thank you. Okay, great. That was perfect. So the next part of the agenda, I think, is something that we all wanted, both our advisors and our task force members, is to have the federal and state laws governing the early intervention program reviewed to make sure that we all understand. So I'm going to call on Ms. Kate Moran and Mr. Matthew, is it Schneer? Schneer, is that correct?
Yes, that's correct.
Near is correct, yes.
Thank you. So Kate Moran is the Mississippi State Lead Office of Special Education Programs, OSEP. And Mr. Matthew Schneer is the team lead for OSEP. And you commented that we are not able to have our attorney here today, is that correct?
Correct. She's not able to attend today. Unfortunately, she is on she's on leave this week. She was hoping to try to squeeze this in, but was unable to attend today. So if we need her to come back to another meeting next month, I believe you all meet monthly, then we can try to set that up as well.
Thank you. Thank you very much. And we may not at all. We do have some very specific questions to ask. I know they were submitted to you prior to this meeting. And so I can just, if this is all right for you as far as a format, I'll read the question.
I don't think we received them, but we'll do our best to answer those questions today. And if there are any that we can't answer on today's call, then we'll get those and make sure that those are communicated back to the committee.
Okay, great. And we've allotted for our task force and advisors, we've allotted 30 minutes for this. So why don't we step through the questions? If you would keep any additional questions you have toward the end, and we would like to address them because we want to make sure everybody has a good handle on exactly when we talk about our task force making recommendations that we're staying within IDEA Part C, all the regs. So the first question that we have is how is the lead agency for IDEA Part C designated?
So the responsibility for designation of the lead agency is through the governor's office. And that's under section 635A10. The governor's office will assign the lead agency to administer the federal Part C funds that the state receives under IDA section 643. And they would be responsible for implementing that statewide early intervention system.
Okay, thank you. What are the mandatory responsibilities of the lead agency?
Matt, do you want to take that, or I can read off some of them that I have, but
Well, I think I can start and we can sort of double team on this. Sorry, we were not as prepared as we had known the questions, but essentially the lead agency must be able to take the single line of responsibility for administering the program. And so that includes the general administration and supervision of the programs, the monitoring of the programs, and enforcing any obligations upon those agencies. They have to provide technical assistance, ensure that any non-compliance is both identified and corrected at least within 1 year, if not sooner. Includes also identification, coordination of all available resources for early intervention within the state, including those from federal, state, local, and private sources, consistent with IDA, assignment of financial responsibility, and the development of procedures in accordance with IDA. Also have to have mechanisms to resolve any intra or interagency disputes in accordance with IDA, and enter into formal interagency agreements. Those are the basics of what's required. Kate, do you want to add anything to that?
the only other one was reporting to the department under the SPP APR, which is the state. I don't know if you said that. I may have missed it. The state
Yeah, I
performance-
missed that one. Yeah.
Okay, State Performance Plan Annual Performance Report, which covers under Part C right now 11 indicators. And then just generally, defining and monitoring your EIS programs, fiscal accountability, ensuring that applicable legal requirements are in place, payment for EI services, and then ensuring timely evaluation, assessment, IFSP meetings, and timely provision of services is being carried out in the state. In addition to those that Matt has, some of those fall under the umbrellas
Right.
that Matt listed out, but I just wanted to add in a couple of those.
Yeah, I think that's helpful. And I think the concept of a single line of responsibility is a very important one for Part C, because it is a program that tends to bring in resources and offices from different agencies potentially. And the point is that as the grantee, there needs to be one single line of responsibility that we can go to ensure all of those requirements are being met. There's also a requirement to have a system of payments, which details out how what type of funding sources are going to be used to support the program.
Okay. I'm wondering, is it better as we go through each question, if someone has a further question, we should go ahead and give it? What would y'all like to do?
That's fine. We'll do
Okay.
our best.
I'm just thinking, does anybody have an additional question about the responsibilities of a lead agency? Okay. I think some may come up as we move forward, but we'll keep going. Are there any stipulations about the structure of the early intervention program?
Really, every program has the flexibility to structure in ways that meets the needs of the state. They tend to be very different across the country in each state. One thing that I would mention is that up until 2021, there was no sub-granting allowed for under Part C programs. So if you were working with a vendor or some other kind of office, that would be done through contractual relationship. In the Appropriations Act of 2021, Congress added the option, but not the requirement, that Part C programs could choose to sub-grant. And then there are a whole bunch of other requirements that come into place in terms of monitoring and other responsibilities if you do subgrant as opposed to use procurement processes or something else for getting the money to the actual providers within the system. Kate, anything you would add?
The only other thing that may be in question with this group is the agency that the government assigns needs to be a public agency. It can't be a private entity of any sort. This needs to be a public agency within the state. Just keeping that
As the lead agency?
correct. It has to
That's-
be a public agency. Yeah, whoever the
That's-
governor assigns as the lead agency would need to be a public agency within the state. It can't be a private program, practice, hospital, things like that. It needs to be a public agency.
And then if I mentioned that you do have the option of subgranting, if you choose to do that, the subgrantees may not be private. They can be public or nonprofit, but they may not be a private and not for-profit entity.
There's a question around how many subgrant. In Part C, there is not a lot. I think the structure that many states have set up allows them more flexibility to not assign the providers as subgrantees of the funding. Matt can speak a little bit more to it, but once you make those EIS programs or providers subgrantees, there are a lot more stipulations and regulations around what occurs and what the state needs to do that I think is carried out often in the structure that many states have in place right now. But Matt, you can speak a little bit more.
Yeah, I would say that, first of all, as I mentioned, the authority to subgrant is very new. So there are some states that have started exploring it, some states that have used it for sort of supplementary activities such as technical assistance rather than for the actual delivery of services, but they are exploring it. I would note, however, there are some states that if you look at their structures, even before we said they could subgrant, they very much appeared to be like subgrants. And that's particularly true. So there are, I think, around 16 states that are what we call ed leads. That means the Department of Education is actually the lead agency, and they often will use a similar structure to what they use with their local education agencies or districts to subgrant. So they're often that, but we don't know of any new states that have started officially subgranting, though there are some that are exploring it right now.
Okay, so that's good. Yeah, so there's none right now.
Yeah.
The answer would be none.
Yeah.
That are doing that.
So would, I have a question. Would this be, for example, if you're looking at a hub model, those would be subgrantees, or is that a model that?
It's how you define it. So if you have, so let's say in Mississippi, you have the 3 health districts right now, and underneath those are EIS providers. So you've got the district level programs, and then the funds go to the providers. In Mississippi, those are not subgrants, and so they operate with the money coming to your lead agency, and then it's sent to those districts and then sent to the providers through that. I don't believe the funds go directly to the providers, but I may be off on that. I'm just coming back to Mississippi after being with some other states on hiatus, but I think it's what the state wants to describe that as in their system of payments and their methods for provision of service in the state.
Well, within the uniform guidance, there is some guidance on how you make a determination as to whether you're subgranting or contracting, and that's something you can take a look at. But keep in mind that there are some specific provisions. So it would be an application rather than a RFP that would be the mechanism for awarding the funds. As I said, they cannot be a for-profit entity. And there's there's a requirement for a risk assessment and more specific monitoring requirements for subrecipients under a sub-granting position, a situation rather than a contracting situation. But as Kate said, we do leave it to the state to determine whether or not they are sub-granting or contracting. It's just that if they determine they are sub-granting, then there are specific requirements we would hold them to that would be different. So as to the reasons why some states have elected to sub-grant, well, as I mentioned, the ones that I'm aware of are ones that are ed lead. So in some ways it makes sense. Sometimes they're used, the same entities that are the school districts may be providing the services already. So it coordinates. There is also, there are provisions within IDA as a program that does not allow, which has a non-supplanting requirement, meaning that state funds cannot supplant the federal funds, but can only supplement them. That limit the amount of indirect costs that can be taken on that. It's called a restricted rate, whereas under contracting, it would be an unrestricted rate. So it tends to be that the indirect costs that come out of that are higher, which may mean there's less funds to provide for the program, but that's not always true. So that's one thing to consider. We do have we do have a technical assistance center that has developed an initial document that sort of reviews the different aspects of sub-granting versus contracting, and we can follow up with a link to that information if that would be helpful.
And there was, I think, a question around, let me go back to the chat. Some of the reasons why some states have elected to subgrant. So in Part C, none of the states have elected to define it as a subgrant at this moment. Most of them are all under this contracting structure. But as Matt said, there are some that are looking at it, but no one has switched over to define, I would say, across their state, we're subgranting. And I think the reason goes to a lot of the stipulations that then click into place when you say we're going to subgrant versus the contracting structure, which allows for a little bit more flexibility in certain areas that I think the Part C programs benefit from or appreciate, I guess. But I don't think we would say one is better than the other, because our Part B programs are under subgrant or do provide subgrants, and that's how that structure works. So I don't think we would say one is better or the other, but I do think some of the programs that are under different agencies outside of the Department of Education, the nuances and the regulations and the requirements and the monitoring responsibilities and the things that would have to be in place, I believe sometimes are beyond the scope of what that staff can really manage effectively, but that's just my 2 cents.
So I did put a link in the chat for the document from our Technical Assistance Center, the Center for IDA Fiscal Reporting, that talks about different considerations on subgranting. So you might want to take a look at that. There was a question about better child family outcomes, the different payment options. Our funds under Part C as well as Part B are formula based. They're not performance based. So you get an amount of funds that's based on the formula, which is essentially based on what's called a base payment, and then population and poverty rates, and then inflation rates and things along those lines. We make it what's called annual determinations of both Part B and Part C programs. This is essentially after reviewing the annual performance report, we determine whether a state is either meeting requirements, needs assistance, needs intervention, or needs substantial intervention. And as part of that determination, we do look at child outcomes data. That does affect the determination, but there is no impact on the actual amount of funds that we send.
And so that's actually the next question.
Okay.
Is there any way to increase the amount of federal funding. So that's a set formula. Are you saying there's no way to increase the federal?
No, there's nothing you could do to increase the amount that you get. It is a set formula. It varies a little bit year to year because of different child counts, as well as obviously depends upon the amount of funds that that Congress appropriates each year for the program.
So just for clarity, it is not determined by the number of children who are being served at the child count time. Is that correct?
There, I have to refamiliarize myself. I think that the formula is based on population in the age range, not with students who are being served. That because it's designed not to be an incentive, a perverse incentive to have more kids in the program. So our IDA hasn't been reauthorized since 1997. They start with a base amount that was based on where funding was at that point, and then look at population and poverty, and then there's some minimums and maximums that determine it. But it's not performance based at all. Along these lines, I would note that as IDA is currently crafted for Part C, the funding from the federal government is often talked about as glue money. That is, it's meant to help coordinate and bring together other sources of funds, but not be the sole source or even the majority source of funding. And that's when I mentioned systems of payments. States get to determine what other sources of funding. Obviously, there would be state funds, potentially Medicaid funds, private insurance, and how that works is all defined in the system of payments, as well as the potential of using family fees.
Using what? I'm sorry.
Family fees, as currently designed, IDA does allow states to choose to charge a certain amount of funds, usually on some sort of sliding scale, if they do that within their system of payments. I don't think the majority of states do that at this point, but there are some that do. And okay, leave it at that.
So you can, not that we would want to, but
Right.
you can charge fees. I did not know.
Yes.
Okay.
In all transparency, the current administration is exploring ways to encourage states not to be charging family fees.
Thank you. What is the state's maintenance of effort requirement?
So the basic requirement is that there's both a budget to budget requirement and ultimately a budget to expenditure requirement. So to begin with, the state has to budget the same amount of funds in 1 year, at least the same amount of funds in 1 year as it did in the prior year. Those funds can include both state and local funds, if there are any local funds that are being utilized to support early intervention. They would not include any of the federal funds that are included. And then ultimately, we would expect that there'd be an expenditure test to show that you actually expended at least as much as you had budgeted.
Any other questions on that from anyone? Okay. Next question is, how does the federal government determine a state's compliance with Part C requirements? And as an add, what are the repercussions or potential repercussions for a state that receives a determination of needs assistance or needs intervention?
So determining compliance is done through several different means. So the first one we've mentioned, so you submit an annual performance report based on the 11 indicators that Kate mentioned. And we have what's called a results matrix, which looks at a combination of the indicators are divided between what we call compliance indicators and results indicators. So an example of a compliance indicator is that there's a requirement that an evaluation be done within 30 days of consent. And we look at the percentage. The requirement is that 100% of all you meet the 100% compliance for that. We also have results indicators, and I mentioned we have child outcomes data indicators, and Kate could probably do a better job of explaining what that is exactly, but it's looking at judging based on entrance and exit of children in the program, what kind of progress they have made towards specific outcomes. So when we review the annual performance report, at the end of that, we generate a results matrix, and on the basis of that results matrix, certain percentages will put you in one of the categories that we mentioned. There are an IDA specific enforcement requirements that are linked to needs assistance, needs intervention, and needs substantial intervention. I will note that we've never used the needs substantial intervention determination since it began. For needs assistance, if a state is in needs assistance for 2 or more years, the general, there are several different enforcement actions we can use, but generally what we would do is require the state to seek technical assistance on the areas that led to that determination, and to report out on what centers they worked with and what the results of that were in the next annual performance report. If you move into needs intervention and you're in needs intervention for 3 or more years, then that can result in a variety of things, including a corrective action plan. It could result in directing funds or withholding funds, or a series of other things in addition to the technical assistance we mentioned. So that's one strand of how we ensure compliance. We also conduct monitoring, what we call our differentiated monitoring and support program. Mississippi is up for monitoring in 2024. And we look at systems of general supervision, including identification, correction of noncompliance, dispute resolution systems, fiscal systems, and several other things. And we issue a monitoring report based upon that, and issue any findings where there is noncompliance and required actions. And then finally, there is a annual application that's submitted to us every spring. In order to be eligible for our funds, you have to submit the application. There are a series of assurances that you have to provide to us, as well as policies and procedures that we review, and we will either provide what's called a full approval if you've met all of the conditions, a conditional approval if there are some assurances that you cannot meet. You will tell us how you will meet, when you will meet it within the next year. And I don't know that we've ever not provided funds, but at some point we issue what's called a stop the clock memo, where we require certain actions be taken before we can issue the funds. So those are our 3 basic ways of assuring compliance. Kate, and want to add anything?
Yes, the only thing I would add is I did put in the chat a link to our general supervision guidance that we just released. It's a question and answer document that deals with what the state responsibilities are. But if you look at sections D and E, those regulations are what OSEP is required, and then specified down at the state level what they're required. But it walks through all of the areas that Matt just discussed, because OSEP's responsibility is to make determinations in those categories, and then the state has the same obligation. So in reading the general supervision guidance, that will give you a good perspective of both what's to occur at that state level, and then what OSEP would be looking for when we make our determinations and our enforcement actions. Although some of ours are a bit broader than what you'll see in that, because we have a few more options. So that's why I would just look at the regulations in D and E. that will outline all the specifics that we can access.
And if you would, those two links that you have put in the chat, if you would email those to Mary Claire, we'd really appreciate it.
Okay.
So that we
Sure.
can make sure the whole task force has access.
Sure.
Thank you. Any other questions on that before we move to the next one? We have about 3 more. Okay, next question. You've already touched on this, but if you would elaborate a little. Do Part C regulations make any provisions for interagency collaboration?
Want to handle
Go
that,
ahead,
Kate?
Matt. No, you got it. Go ahead. I'm
Um,
copying the link, so.
I mean, there are provisions for interagency agreements. There is a requirement that, for example, there are interagency agreements that are required with the Part B agency and any other agency that might be providing information or providing funds or services, typically with Medicaid or other offices within the state. We can get the regs for those requirements.
I think some of those are actually in that general supervision guidance document. I was trying to look them up quickly. And then one other thing that I think we forgot to mention when we were talking earlier on the responsibilities, a big distinction between Part B and Part C is the provision of services in the natural environment. So to the greatest extent possible, that those services are provided to the child in whatever their natural environment might be. So if that's in the home, that it's provided there. If it's in a daycare center, that it's provided there. So that consideration, I think, is really important to make as a distinction between Part B and Part C. I know that's a little off topic on the question, but I think it's really important to keep in mind as you're thinking about your evaluation of the system, that natural environment is what has been found to be most effective in the provision of services for our infants and toddlers with disabilities.
Right.
I would just going back to the other question, I'm just looking at, there are also requirements for coordination with agencies such as Head Start, early Head Start, early child care programs, a variety of things along those lines.
Medicaid, did you say
Right.
Medicaid? Yeah.
Yeah.
Deafblind.
So the natural environment can be the home, the child care center. Are there other natural environments that would qualify, or is it particularly those two?
It's really dependent on the family. I mean, where the child is during the day would be what you would want to be working to understand and working with that family, because that's where the service. So I'm trying to think that like daycare and early childhood centers, I guess, if that's where the child is during the day, if the parent's working, then that would be the natural environment. Sometimes I guess virtually, I don't know. I can't think of others, Matt.
That's what I'm remembering. I'm looking at the definition right now. In one moment. So it means settings that are natural or typical for a same age infant or toddler without a disability, and it may include the home or community settings. So it specifically, it would be not a place that you're going to because the child has a disability. It would be a natural setting. And the concept behind that is that the infant and toddler is going to develop better within that natural setting and getting the supports that he or she needs to develop that way. And I think one thing important about the Part C program also that distinguishes it from the Part B program is that the family is a partner within the program. Under Part B, we have what are called individualized education programs. That's the plan that talks about what needs to be done. But under Part C, it's called the individualized family service plan. So the family is a part of it. It's not just an educator with the infant and toddler. It's in coordination with the family.
Any further questions on that?
I had a quick question. I was trying to put it in the chat. Does that differ for where eligibility evaluations should occur and therapy services? So are eligibility evaluations also supposed to happen in the natural environment, or does that stipulation just refer to the services, the therapy the child gets as part of their IFSP?
I don't think, but I'd probably have to check back to make sure that it applies to evaluation. I think it is about providing services. And to be clear, it's not a compliance indicator. So it's not something that says you can never provide services outside of the natural environment. It is what is preferred. So when I mentioned the results and compliance indicators under the APR, natural environments is a results indicator where the state gets to set its own target for what percentage of infants and toddlers are served in the natural environment. It's not non-compliance to serve somebody out of the natural environment. It is highly encouraged.
And services as well, I would say, include speech, OT, PT, all of that, those
Right.
therapies, if that's what,
Related services,
those are encouraged to be conducted in the natural environment as well. And that's in the red. I mean, you can see the listing of, what we consider early intervention services.
So that really leads into our next question. What kinds of services do the federal and state regulations require the early intervention program to provide?
All right. Let me pull that up. I think it's under. Do you have it in front of you, Matt?
No, I'm looking. So go ahead.
We go here. It'll be in 303, and then there's it's probably in the 100s. Go back up here. Long list of them.
So I think as people.
I mean,
Okay, 303.113. So I'll put this in the chat as well. And this has this talks about what early intervention services are provided under public supervision, are selected in collaboration with the parents, or at no cost except subject to the ones we've already discussed around family fee schedule. Let's see. And then there's a long list: assistive technology services, and then it goes through audiology services. A whole bunch of services are here. So I'm going to put this in the chat, and I'll also email this link. But there is a long list of services: nursing services, health services, medical services, nutrition services, occupational therapy, physical therapy, psychological services, service coordination, sign language, and CUE. I could keep reading, but I'm sure you guys
I want to
can check
emphasize
those out as well.
the service coordination one, because that's essentially a mandatory one, that there be a service coordinator to coordinate all the services. And I think the important part is that this is it's not a requirement that you have a specific service. It's a requirement that there be an evaluation done in collaboration with the family to determine what services are needed to provide the appropriate services to the infant or toddler.
And I just put in the chat that 303.34 is the regulation around service coordinator. Now, again, I'm putting these in an email that I'll send to you.
Thank you.
Yep.
Last question. Oh, did you have an add-on?
I was just looking at the chat questions. Did you want us to try to address those?
Sure.
And there was one question about any stipulations support or incentivize rural providers to provide services in the natural environment, given the additional time and challenges it takes to do that. I don't think there are any specific provisions. There is a requirement in IDA that there be geographic, geographic equality? I can't remember the term anyway, but that there are basically not variations around that. Obviously, the challenges of rural areas are significant. And that's why there may be variation in natural environments areas. We monitored last year a western state that was very rural and big, so there are a lot of concerns around that, but no specific incentives. And then there was a question: when might the state consider making subgrants in reference? Can you speak to the suggestion of using a subgrant if the state needs ongoing support from its EIS providers to accomplish its goals? So that I gather that's a quote from the resource that we linked to you. I'd have to take a look at it more directly, but I think that it's an interesting question.
Yeah, I'm happy to give more information. So I was just reviewing the reference.
Yes.
And so the question was, when might the state obviously consider subgrants? And under the contract column, it stated that the contracts might be useful when the state lead agency needs a specific set of goods or services to accomplish their goals, versus on the grant subgranting, it says subgrants might be useful when the state lead agency requires ongoing support from its EIS providers to accomplish the goals. So I was just curious if there was any more guidance on that difference.
Well, certainly on the contracting side, I mean, what the contract provides you the mechanism to do is to develop a specific contract with all those terms of services and performance measures and other things along those lines. The sub-grant is going to be more standardized, and it does assume that the sub-grantee is capable of carrying out all of its requirements on an autonomous way, subject to the type of monitoring that would be expected. But to be honest, I would need to take a look at that a little bit more. We can try to provide some additional information if you'd like. Okay, I think those are all the chat questions I saw.
Okay. Are there any other questions? I think this was great information. We really appreciate your time coming today. Thank you so much.
You're most welcome. So I think Kate will follow up with an email with the different links that we provided. Feel free to get in touch with us, work with Stacy on any questions. And if you decide you need some more technical information on some of the legal requirements, we can speak to it to Kala Supranant to try to get her on at another time. Okay.
The only other thing I would want to mention today is if the group is considering changing the lead agency, or if that is kind of a recommendation that may come out, that there are a lot of steps to having that happen. I think Beryl is on the phone, and we have shared with her and Stacy a listing of considerations. That process, it's recommended that we really start looking at that for a period of time before it switches over. There's funding issues, which you all are clearly aware of because you're talking about it and asking the right questions. So the more we can be in touch and in contact, and we'll work with Beryl and with Stacy on hopefully ensuring a smooth transition if that's something that comes out of this and that the governor moves forward on. So, but we're here to support that and talk about timelines as well, which may be a conversation we might want to circle back to as you all come closer to making your recommendations. That might be something to talk through, at least what the what the barriers may be if we go one way versus another way, or when things become enacted. Not to say do one or the other, but just to talk through what those mean from our funding, so that we can ensure that Mississippi is able to get the grant of funds in a timely manner, and that those aren't delayed and things like that, that we've observed in other state programs. If we don't have certain things in place, then we're not able to issue the grant, and we don't want to have that happen. So I've just observed it in another state, and I just want to make sure that Mississippi doesn't end up in that same scenario.
Absolutely.
Okay.
Okay. Thank you for the opportunity. Take care.
So much.
Bye.
Bye-bye.
Okay, that was Good information. Let's go to the next point on the agenda. We have Dr. Heather Hanna from the Social Science Research Center at Mississippi State, who's going to talk to us about the availability of data. So, Heather?
Thank you, Dr. Buttress. Is it okay if I share my screen?
Yes, certainly.
Great. Okay. Okay, so I am going to share with you today a policy brief that we pulled together here at the Social Science Research Center where I work at Mississippi State University on the First Steps Early Intervention Program in Mississippi. This was a product of the Mississippi Thrive project that I know many of you are familiar with. It was a 5-year Health Resources and Services Administration funded project. And really the goal was to improve the developmental and behavioral health of young children. And it was a partnership between the Social Science Research Center and the University of Mississippi Medical Center. And of course, Dr. Buttress was the lead principal investigator. So this policy brief was released in 2022, January, but the data were collected in 2021. So let's bear in mind, there is a little bit of a time lag. And really the purpose was to look at opportunities and challenges for providing services through the early intervention program in Mississippi, of course, with our goal of looking at the overall developmental health system in Mississippi. The EI program is naturally a huge part of that, and everything is interwoven with that program. So we conducted a desk review of some of the First Step program documents that are publicly available, including their annual performance reports from 2005 to 2019. And we also conducted 23 semi-structured interviews. 11 of those interviews were with early intervention service providers. 10 were other early childhood developmental and behavioral health stakeholders, and 2 were we classified as other. And we also calculated a return on investment if Mississippi were to be able to serve more children in our early intervention program. So the findings that we had were around a number of systemic challenges, both within and outside of the early intervention program in Mississippi. It will not surprise you at all to hear that one of the things that really rose to the top was state funding for our early intervention program. As Mr. Schneer was saying earlier, early intervention is funded through a federal program that has a formula, but then states contribute as well. And in fiscal year 2021, Mississippi contributed only 23% of our program's total budget. And according to the source that I'm using today that will allow me to make some comparisons of these figures across states, we provided services to 3.8% of eligible children. And really those figures often, they'll vary slightly depending on a number of factors. And I think, Mitchell, you're going to talk about a formula that we have now in Mississippi for determining eligible children, but let's stick with the 3.8 for comparison purposes for this presentation. So at that time, the national average was 6.8, and we know that Mississippi should have many more children eligible just because of our poor social determinants of health, including low family income. So we would have thought we would have much higher than 6.8 in Mississippi that we were able to serve with our funding. So West Virginia, and they're a state that has similar social determinants of health as Mississippi, they were contributing 72% of their total program budget, their state was, and they were able to serve 13.8% of eligible children compared to our 3.8. And in New Mexico, another state that struggles with poverty, they were contributing 90% of the total program cost and serving 22% of eligible children. So that gives you an idea when other seemingly struggling states are providing that level of program funding. So what are the costs to the state of Mississippi for not investing in early intervention? We decided to take a look at that. We were working at the time with a group called Manit Health, and we built off of some calculations that they had provided to us. And we determined that if that year Mississippi had matched the national average and served just 6.8% of eligible children, we could have saved as a state $3.5 million, and that's 1 year. So if we extrapolate that out for 5 years, we're looking at over $17.5 million. And that's just savings from avoided special education costs. They do not include long-term savings associated with high school completion, workforce participation, et cetera. So let's see. Another structural challenge that our system faces is our provider contracting scheme. Service providers do contract with the Department of Health, and they're required to renew these contracts annually. And this can result in delays and service disruptions. At the time in 2021, they were paid very low rates. I know there's been some movement on this. And the rates at that time were even lower than Medicaid rates. And they reported to us in this study that there was a considerable administrative burden through paperwork, required trainings, multiple EOBs, explanations of benefits per child to get reimbursement. So the end result is it's hard to be a service provider for early intervention, and consequently too few providers are available for children in the state. Another systemic challenge is accessing timely and effective services. So as Mr. Schneer and Ms. Moran were saying earlier, each child is assigned a service coordinator who serves as that point of contact. However, often the service coordinator caseloads were reported to us as being very high, which impacted their ability to communicate with the children after they had been referred. Sometimes the call was delayed. And really there's a lack of information on the parents' end as to what they should be expecting to happen. And so there's a little bit of a disconnect there. And it was brought out in our interviews that many children need services that are not typically provided through our First Steps program. As again, they were saying, there's a huge emphasis at the federal level for providing services in natural environments. Our respondents did note the difficulty of this just due to the low number of providers and the high caseloads, how rural our state is, and in some cases, a lack of understanding of the importance of natural environments and really the centrality of that concept to the program. So we did not talk to any parents or caregivers, but the stakeholders and service providers that we spoke with did offer some observations about what they see as family impacts of these types of structural issues. One is difficulty finding appointments close to where they live that, work into their schedule. And they said this can be really hard for families where English is a second language, or, your financial circumstances can make it hard to maintain stable contact information. And also, insurance status was reported to us as having an impact such that if a child has private insurance, they're more likely to be referred to private early intervention services rather than First Steps because of the perceived structural barriers to care. So I wanted to, since, it has been a few years since these data were collected, I did want to provide an update There have been, we know, some areas of improvement. We know that the Department of Health has been working with their CSPD group to try to get technical assistance and improve the workforce. There have been recent increases in service provider pay rates. I do not know what types of increases those were. I just know they exist. Transition notification from Part C to Part B, I'm sorry, got high marks in our last annual evaluation, though there was still room for improvement on having a timely transition conference and plan. And then some continued opportunities, that presented themselves in the conversations that we had are ongoing. And one, of course, is program funding, the numbers that are being served relative to the need. We still have issues with timely service provision and services in natural environments. So that concludes our findings. Thank you for letting me share them.
Thanks so much, Dr. Hannah. Good information. Okay, I'm going to take executive privilege and ask that we take a 1-minute break to just stand up and twirl around or stretch or do whatever and sit back down. Feel free if you need to take another type of break, but we'll keep going. So 60 seconds. I lost my crowd. It's been a minute. Maybe I'll give it to you. Okay, why don't we get back moving along? We have a couple of people still out of the room, but I think we can move ahead. If those of you who have your cameras off, feel free to turn them back on when you come back on, just so I know you're here. Thank you. Okay, next we're going to go to Dr. Courtney Walker, who is a psychologist in the Department of Psychiatry at the University of Mississippi Medical Center and a task force member. She'll be presenting on the issues around infant relational health, mental health. Dr. Walker, you have the floor.
Thank you. And thank you for the opportunity to serve on this task force and just to provide some commentary around the mental health needs of our young children. I don't have a PowerPoint presentation. I just wanted to discuss a few things I had noticed in my time in this task force and as a provider as well. So I am a licensed clinical psychologist and I have specific expertise in infant and early childhood mental health. For those of you who may not be familiar with that term, when I say infant and early childhood mental health, that refers to a young child's capacity to experience, regulate, and express their emotions, form close and secure relationships, and explore their environment and learn. To many people who practice in this field, it is the literal foundation of a child's ability to learn and gain new skills. So as I've listened to the testimony of others, I've really been struck by the lack of attention that's given to the mental health care needs of our children and the children that are served by early intervention. According to the CDC, approximately 10 to 16% of young children experience clinical mental health conditions, and this number is higher for infants and toddlers who are living in poverty and who have made or experienced adverse childhood experiences, including neglect and abuse. We know that a significant proportion of children birth to 3 in Mississippi are living in poverty. So a lot of our kids are at risk for those mental health conditions. The good news is that Part C does allow for the provision of some services to address some of these needs in the birth to 3 population. So, for example, if a child has a significant social emotional developmental delay, they are eligible for services under Part C. And so some examples of what those services could be family training, counseling, home visits. And this is quote out of some of those documents that were also shared by OSIP. So family training, counseling, home visits, as appropriate, provided by social workers, psychologists, or other qualified personnel. Psychological services also can include psychological counseling for children and parents, family counseling, consultation on child development, parent training, and education programs. But as far as I understand it, there are no licensed mental health professionals included as providers under our Part C program. If a social emotional delay is detected and it's part of a child's treatment plan, these delays are often treated by other allied health professionals who may not have the training that they need to provide evidence-based treatment for those concerns. We also know that children with developmental delays often have comorbid social, emotional, and behavioral problems that significantly impact their ability to engage with those other developmental therapies. So a common one that I see in my practice and that we see in the literature is a child with a language developmental delay. We often see comorbid behavioral problems with that developmental delay. But because we do not provide those sorts of services under our Part C program, a speech path who is a approved early intervention provider is often left to figure these things out on their own, despite not having the training or the resources available to them to help them through that. And you can also see how this becomes a problem for children who are also diagnosed with autism spectrum disorder. So as far as I am aware, there are no behavioral supports or counseling services or anything available through Part C for our children diagnosed with autism spectrum disorder. We also know that children with certain biological and or environmental factors are at risk for developmental delays and behavioral health conditions. So a child who might be exposed to substances in utero, like alcohol, smoking, methamphetamine, are at high risk for developmental delays as well as mental health problems as they age. But if these children do not have a significant developmental delay, we do not serve them under our Part C system. So if they are considered at risk, but they don't meet criteria, that means that we don't serve them. So kids who have a well-known risk profile of mental health problems and behavioral health problems later on in life, they have to wait until they are showing a clinically significant problem until we do something about it. And, you know, you have to ask yourself, wouldn't it be a lot easier and probably less expensive to prevent those problems and treat it? That's a rhetorical question. Yes. The literature on that is very clear. It is way cheaper and way easier to prevent rather than treat, especially when we get into the realm of mental health conditions. So it's really important to note that very few Part C programs provide mental health services or those counseling services. So we really aren't alone in this. I want to highlight that. I do know, though, some of our neighbors, specifically to the south, or kind of to the south of us in Louisiana, have several initiatives that provide infant early childhood mental health services through Part C. And I really do think that we can do the same, and we should do the same. I am aware that our early intervention system has made some efforts to train existing staff in infant early childhood mental health, and I really applaud them for this. This is really great, and I think cutting edge. I'm also aware at some point in time, our early intervention system was exploring the idea of offering applied behavioral analysis services as part of Part C, and that's a specific service for children with autism spectrum disorder, and that would be fantastic. But I have yet to see any real progress in incorporating behavioral health and mental health professionals in the Part C program, and I really hope that we can see that change with the work of this task force. So, thank you.
Thank you, Dr. Walker. Okay, next on the agenda is a discussion on Mississippi's eligible population and brief instruction on how to use interactive population data tool. So this is by Mr. Mitch Adcock and Dr. Larry Smith from the Center of Mississippi Health Policy to go over this. So Mitch, I'll turn it over to you.
Great. Good afternoon.
Explain what you're going to talk about.
Yeah, real quickly, I just think it's, I'm going to share my screen real quickly with you. Make sure it comes up. No, wrong one. Hold on. Let me unshare it. Well, let me pull this over. Wait.
We can see your screen right now.
Yeah, but it's, the wrong one came up. Let me see. I've got like 4 screens here. So, oh, here it is right here. Okay. Okay. Can you see it with the says Early Intervention Task Force 2023?
Yes.
Okay. This is something that's on our website. I know Pierre has sent this information out to you to look at, but we've got it at a central location for you to review if you'd like to. We summarize this information. I think it's really important to determine which children are we talking about and how many of them there are and where they're located at. So we went through and did some research on some information from the Early Childhood Longitudinal Study Birth Cohort related to early intervention services. And that's a national study. It's an ongoing study. And that information provided that about 13% of those children from birth to 36 months are potentially eligible for early intervention services. So you display those traits that would need those type services. In addition to that, it showed that there's 4 demographic information characteristics that also provide for those children. And those are things that Mississippi really lead the nation in. And so it makes it much more prevalent, and probably our numbers are going to be a little bit higher. That's low income, racial, ethnic, minority status, non-English home language, and then low maternal education. So this brief is just a page, 2-pager from that study. So you can go through and pull out some of the information that they have on that. So what are we talking about from that data? We put together some charts. This is a chart that shows from birth to 3-year-old children in the state. It comes up in a chart by county, and it shows how many of those children, that's total population in that county. It also has a chart on there, so you can just hover over that chart, that county, and it'll tell you what the total population in that county from 0 to 36 months are in there. And this is from U.S. Census data. So you can go to each county and make a determination, and those in darker colors have a higher population. That's total population. It's not potentially eligible. The next chart is those likely eligible. That's within that 13%. So these are the people, the children that should be served by Part C. There's a tremendous number of children in that category in the state, especially versus those that we're serving currently. And again, you can hover over that map and you can see exactly how many children are in that county that should or be able to qualify to receive services for early intervention. In this chart, you can click here and it'll sort it by ascending or descending order, and you can see which counties have the largest population for that. So the first one told you total population, second one shows you those that should be potentially or likely eligible for Part C. But also, you saw race was another demographic that is important, and it's going to come up in a second. But you can hover over each one of these counties, and it'll tell you what the makeup for that county is by race. And this is 0 birth to 36 months. And again, you can come down to the chart and you can sort it ascending or descending. You can get it in order to see, what that population is and compared to other locations. Something we thought was interesting that, you guys who are familiar with population Mississippi, when you start doing Asian or Pacific Islander, then you see, individuals on the coast and so forth, the population. So all those things that need to be taken into consideration when you look at this population, but you also percentage of Mississippi population not graduating high school. And so this is on educational level. And you can go to each county and you hover over it and tell you the failure to graduate rates. And you can also sort that in whichever order that you want to, or you can do it in to look at that data. And then also home language, not English. And again, this will show you those counties that have the highest rate of that population. And again, you go down the chart, you can sort it. All this is to where you can prioritize and see, locations in the state where we have problems. And of course, income, poverty rate in Mississippi. And you'll see this trend. Everybody knows this trend in the state, but this will give you a set number to it. And it goes all throughout the Delta, which these rates are the highest, with this Quinn to be in the highest number. So we thought it was really important that you could make a determination of, and my computer's thinking for a second, so give it a second. You can make a determination of where this population is, or those individuals that need to be served for the early intervention program. I know we talk about the situation of the need to serve this population, but it's really important to be able to put a number to that and see where those individuals are. The total number, if my computer will cooperate here in a second, is around 18,000 children in the state who would qualify for early intervention program. And that's a tremendous number. And just the preliminary numbers we've seen show that many are not being, provided services today. So we don't have that number right now. And give me just one moment. There we go. All right. Are there any questions that you might have about this? We're going to make these accessible to you so that you're able to pull those numbers down. There we go. Sorry about that. And again, you can click on this site and you can go to each one of these charts and you can go to whichever individual county that you want to look at that. And this is, and I'll show you the bottom of this chart one more time. And that's a total of 0 to 36 months population, 144,000 in the state. And well, where did it go? Likely eligible. I can show you quicker on this. And here are the summary numbers within this brief: 144,000, 18,786. And this is a breakdown by racial. Any questions?
I'm not seeing any questions unless something's coming up in the chat.
Okay.
So thank you, Mitch. This is excellent information. Is Dr. Larry Smith going to also speak?
No, he's just here to answer any questions that you may have about the data. He's wanting to pull the census data together.
Okay.
And those maps can be overlaid by where providers provide services. You know, one thing we thought about that you may look into at some point is on providers who have provided services, Medicaid reimburses for some of these services. So Medicaid could possibly provide data of where paid claims are, and you can put them within the county of where those individual children are, and then you could see, how many services being provided in those areas or anything like that. Anything geo mapping, Larry should be able to overlap the maps to show you versus the population versus where services are being provided. So.
Thank you.
Mitchell, I had a question. I'm wondering, how did y'all land on these particular characteristics as criteria for what would be eligibility?
The cohort, the study showed that these 4 demographic areas contributed more highly to that area. So we picked them out, and and you mentioned in your presentation how Mississippi rates versus other states. And in most of those areas, we rate lower. So that 13% across the board rate, that's a national average. Most likely Mississippi's numbers are going to be higher than that.
Mm-hmm. Okay, thank you. That's helpful.
Hi, this is Dr. Tanya Fitz. I do have a question. If we were to query for where service providers are, that would be very helpful. And also query if it is, Medicaid. I am not certain that the Division of Medicaid would readily provide us their claims data.
They used to. They don't put it out on their website anymore, but peers supporting you, so they make an ask for it in unidentified data. But they used to have a provider database of so much specialty that it had early intervention as a specialty that they were reimbursing providers for. And at least with that data, we could put it, geomap it. We would do it at a county level, so we're not getting so specific that we're giving you an address.
Yeah, I think that if we could request that data, Dr. Buttress, that would be helpful. And that would give us a partial picture because, as we know, commercial insurances also are providing some services through early intervention, but to look at the children in poverty, it would be helpful to have that Medicaid data.
Can query that, so they will. Thank you, Dr. Fitz. Okay. Well, we're going to move to the final item on the agenda. We'll talk about the September meeting, but before we do that, I'm going to turn it over to Dr. Dan Edney. I think everybody knows him as the Mississippi State Health Officer, and he's a task force member. And he's going to talk about the summation of the information that we've gathered over the last few weeks from across the state. Thank you for everyone who's given input. And he's also going to talk about the forward movement of the early intervention program. I just have to give kudos to Dr. Edney. I know he's been in this position for a year. And, I think he is very interested and engaged in making sure that we're best serving our children. So with that, Dr. Edney, I'll turn it over to you.
Thank you, Dr. Buttress, and thank you, task force members. What I thought I would do for you is to bring you full transparency into what I have found as the executive director of the Mississippi State Department of Health with a program that has historically been challenged. And I mean, historically. And I also want to speak to you as your state health officer, because those are 2 very different hats. So as the executive director of the health department, I have a strong desire that all of our programs demonstrate excellence that they are achieving the mission of the health department, which is to protect and advance the health, safety, and well-being of everyone in Mississippi. Now, how about that for a mission statement? That's a heavy lift, but we take it seriously. And early intervention is part of that. And for our jurisdiction, it is a small part of that, but it's an important part of that. I wish that access to early intervention services were the only access issue that I was identifying statewide. And I mean, just for our infants and children across the board, all health indicators, our impoverished families are having difficulty accessing care for just about anything. And EI is a good example. The difference is this is an area where I have some authority and can work with partners to make it better. And I would say we need to make it better quickly. So a year in the life of a new state health officer, we've had multiple challenges. I counted 13 unique public health urgencies in the last 12 months outside our normal scope of work that we have intervened and done so well and corrected those urgencies. But the issue of early intervention first came on my radar scope in the transition between Dr. Dobbs and myself in a meeting with Senator Nicole Boyd and listening to thoughtful concerns. And of course, my learning curve is very steep. But it became pretty obvious to me that access was a major issue. And so the first thing I did as state health officer was really my first order as the state health officer. I had already identified that our provider rates, as already been pointed out, were horribly low. I mean, below Medicaid, when you're being paid below Medicaid, you're doing missionary work. And we all know not everybody's called to missions, so not everybody's willing to do that, and they shouldn't be expected to do that. And of course, that's the rates I control or the rates that go as the payer of last resort. But that's an important group of providers. So my first order was my chief administrative officer pointed out to me that there was a bucket of money that had kind of accumulated through COVID that were, I had the discretion on how to utilize it. And rather than invest it in agency salaries or agency overhead, I made the decision to push it out to providers and ordered a 20% across the board pay increase in the fee schedule. And I also asked for there to be incentivization for provision of care in the natural environment. So trying to overcome that inertia, which, even at that early stage of understanding, I picked up. And then many other things started happening, like Jackson water crisis and monkeypox and rural hospital crisis, and go on and on and on. The next issue that hit my desk was the fact that early intervention was not billing for targeted case management to Medicaid and not billed in over a year. And those were desperately needed resources. And my first question is, why in the world are they billing when I have a revenue cycle team that's experts at it? And look, I don't know, I'm not an expert in childhood development, but I can tell you a thing or two about billing and collecting from Medicaid. I've done it for 32 years, and I took that from the program and moved it to revenue cycle, who immediately got their arms around it and started bringing in the revenue from Medicaid. I'd like to point out, most of you probably don't know that at the end of the year, we pay our Medicaid match for everything we bill Medicaid for, and that includes early intervention. And so at the end of the year, we'll get a bill from Medicaid for 25% of what they reimbursed us for. And the health department pays Medicaid so that we can draw down more federal dollars. Now, we do that voluntarily because it makes sense to improve our revenue stream to the state. We got that corrected pretty quickly. And then I find out about our compliance issues with the federal grant. And I'm not finding it, I'm not finding out through the channels where I should be. So these are all problems hitting my desk from alternate channels rather than from the program. That's a problem. At that point, I knew we had to do a deeper dive in what was going on with early intervention. The more I dove, the more I realized that there was a culture of saying no, and there was a very powerful silo there. We've worked hard this year to dismantle the silos at the health department. That was one that has remained. I'm working on that as we speak. But I was learning of a culture of not being cooperative with our community partners and apparently not respecting thoughtful recommendations from our advisory groups. For me, just like common sense things if you're running a program. And, and first thing you need to know is what you don't know. And it's become very obvious to me that the agency, and I think this would be true probably of any of the state agencies in health and human services, we don't have the professional expertise to manage providers. We have a lot of expertise in managing programs and managing grants, but I just believe this program has surpassed the expertise needed to run it the way it has historically been run. A critical decision was made 5 years ago. You and I talked about, I think, was critically important in downgrading our ability to serve the public. And that was 5 years ago, the decision made to centralize early intervention. I hate that. It should not have happened. It did happen. And I think, and just looking at the trajectory of things have gotten worse over those 5 years. The first bright spot was when I ordered the increase in the fee schedule. And we had significant positive response for providers. We've had a significant increase in a number of providers. And hopefully that'll translate into the number of children that are served. What I have to do now, this is my work. This has nothing to do with peer. There's nothing to do with the task force. This is, my agency identifying problems within my team and understanding that, we had to fix things. What was interesting is over this last year, I'm not getting a lot of input from outside the agency. And so the stack of comments and complaints, which I assume are all valid, and we're processing through them now as we do all complaints at the agency. I had none of that to work with over the last year. I had, and goodness gracious, I have legislators call me for the smallest of things. And in my opinion, this was not the smallest of things. What I want, and that told me that fault is on us, because obviously the culture made it to where you did not feel comfortable to call. And what I'm telling you today is please inform us at the agency of agency problems that you're dealing with. I want to reassure you that we actually know how to do things at the health department. And we do things pretty well. Here is an area where we're not doing well. But I brought my A team, Dr. Victor Sutton, who's over community relations and clinical services, and my senior deputy, Ms. Chris Adcock. Dr. Sutton was responsible for moving us through the pandemic and eliminating the vaccine health disparity that was killing hundreds of African-American Mississippians and flipping us from being the worst in the country to #1 in the country. And I personally credit him and his team for saving about 3,000 Black lives in Mississippi. He knows how to get things done. Ms. Adcock is my cannabis queen. She was recruited to the agency for Office Against Interpersonal Violence by Dr. Dobbs. And then when the gift of medical cannabis was given to us, she was assigned to stand up that program from scratch. And we had 4 months to do it. And she met and she did the heavy lifting. There were a lot of members on the team, but she led the effort and got us there on time. And we met all of our statutory timelines, and the program is maturing and doing what the legislature wanted it to do. So that's just 2 examples. We know how to do things. And I will tell you, this is not the most complicated problem on my desk right now. It's the most frustrating, the most aggravating problem, because it's absolutely unnecessary. And it will be dealt with. I don't care if we're a lead agency or not. 3 weeks ago, I'd have been the first one to vote yay, move it. Get it off my plate. But the more I learn about this wonderful program, the more I see the importance of it, that niche of special children who need special attention, you know, and if health can't do it, I really seriously wonder if anybody can, if we do it correctly. So I'm telling you, we can fix this, but I want your help to fix it. I want us to work together to fix it. I don't want to wait till December to fix it. So we can spend 2 more meetings going through the whole list of things in the history of early intervention, or, I mean, I told you last meeting, I'm convinced things are going to change. I've learned more since last month. I'm about to tell you what has changed and what will continue to change. Then I'm going to give you an honest assessment of what I think the health department should be doing and what we should not be doing. And hopefully, let's all start moving in a direction where partnership and collaboration will take care of our kids. So the first thing that I've done is I have taken the director of early intervention, who also is over child and adolescent health, and relieved her of her responsibilities, and except to be in a consultant mode for me and my executive staff. I have taken the director for health services that houses early intervention as one of its important programs. I have relieved her of her responsibilities except for child and adolescent health. And in their place, Ms. Adcock will have direct responsibility in administering the EI program. And she will bring to it the same level of excellence that she has brought everything else in her more than 20-year history between departmental health and us. And actually, God bless her, she dates back to the mental health days of EI. So she has capacity here. And Dr. Sutton, in addition to everything else I have on his back, will now be stepping in to run health services. There will be the day-to-day operations of normal things will keep going through the EI office, but there will be no administrative decisions made without it being at either Dr. Sutton or Ms. Adcock's level, and they both are direct reports to me. I will know what's going on with this. It's a frustration when you're being shielded from problems that need attention, but we are fixing that. We will, as we move forward, as the task force continues to do its deliberative work, we are not just going to go, we're not just going to tread water. I had already ordered, it was during the legislative session when y'all were meeting, and I didn't even know y'all were meeting. That's how lousy communications were. None of my executive leadership knew that y'all were even meeting, or we'd have been here. And I apologize for that. We had no discussion or input into the academic hub pilot. Didn't know about it. That's on us, and I apologize for that. I had already ordered for them to give me every advisory group report and recommendation to show me what we had adopted, and the things that we had not adopted, I need a written explanation why, and why legally we could not do it. And I just took it upon myself to dig through. And what I saw were what we see with all of our advisory groups, good, thoughtful recommendations from experts in the field. That's why you have advisory groups. And so I was in the process of ordering the simple things. And then there's a statute, requiring us to do what I just ordered. That told me everything. When you're so frustrated that you're getting legislation passed to try to make us do something, I'm just going to tell you, under my administration, it ain't going to be that way. We're not going to do business that way. So I think y'all know, I think I'm the 5th health officer to have to deal with this. The 2nd state agency that I know of to try to deal with this. We're going to get this done because we're going to do it differently. So Dr. Buttress and I have spent, some good time talking about alternatives, and the more I thoughtfully, independently, on my own, look at the options and where our level of expertise shines and where we're deficient and where there are community partners who will do a better job than we can do. That's where we need to move. It's obvious that the history of EI is too troubled to try to fix the way we do it. But what we need to do is move forward with us focusing on our areas of expertise and having the right partners in place out in the field, working with providers, using their expertise and ensuring that children are getting served the way they need to be. We will continue with a deep investigation within the agency. I don't care who else is looking. We're looking for our own purposes. So we will now move to the next layer of leadership, and then we'll move to the next and the next and do a thorough evaluation. We will be auditing the federal program and the compliance issues there, and we'll do that through our internal audit office, which is independent of the agency. But we're going to know exactly what has been going on and what we need to do to correct it. So in my opinion, we need a decentralized approach. We need to reverse the decision from 5 years ago. Referrals and enrollments need to occur in the communities and not in the central office. The health department needs to get out of the business of trying to manage providers and provider networks. That is not what we do. We do a reasonable, because these are private providers. Now, we do a reasonable job with our public providers. We don't have the bandwidth or the expertise to be trying to manage the problems of private providers. That needs to be done with people, with our partners in the field with more expertise in that area. We need to get out of the way of our experts. We need to let the expertise, we have world-class experts in this area. We need to let them shine for the sake of our children. And I don't care who gets credit for this, let's just get it done. But the health department needs to step back and get out of the way. It's very clear to me that there's been some issue with control and turf, and I just don't do that. I don't play that game. It's a waste of time and a big waste of resources. But I'll tell you, I do think state agency leadership, and you heard it from the feds, is critically important. There are things that we can do that others cannot do. And we do a great job when I have the right leadership, the right program design. We have excellent outcomes in other programs. We have exemplary compliance with our other programs. Other programs I am proud of that just nobody pays attention to them because they do so well. But at the end of the day, I am fully convinced that this program needs a hybrid model, a combination of a lead state agency with the right partners in the hub model. But that brings forth a lot of questions. And this is where I think our time will be well spent. If we can come to a consensus on the general outlook of how a new model would be, and not imposed by anybody, but a consensus model. And then we have to start working through the issues to make that happen. That's going to take some time. It's going to take some work. I have 32 years history of working on every task force you can imagine. Task forces are not meant to design and build programs. They're to do what we're doing now. That's to identify problems, bring consensus to the table, point people in the right direction, then put the right people working the problem. We have limited time. January will be here very quickly. And if we're not ready with a model design that will require specific funding, then we'll lose a year. And I would rather we not do that. We need to know what the funding needs with the new model will be. It's already been identified that this program has been historically chronically underfunded. Last year was the first significant increase, and had we not gotten that increase, which 100% of that appropriation is going to providers. I hope y'all know that. It's not staying at the agency. It's going out to providers. Had we not gotten that, we'd have run out of money to pay providers at the rate we're paying, but we can sustain it now. If we're doing hubs, we need to know what the funding needs for that will be. We need to know how the funding stream needs to flow. We need to identify who's going to do targeted case management. Targeted case management brings down those Medicaid resources to help fund the program. If we're going to continue us funding the match, then it's going to have to be in our house, but those funds will move out. Even if we continue targeted case management, I don't know that we need to. We'll continue the match and push those resources out. We'll need to insulate the program from budgetary pressures. We have been through a state budget crisis, 2016, 2017. That was not very long ago. It could happen again, and typically they're across the board budget cuts. If EI were to have increased funding and then get cut, we know the federal repercussions of that. So we need to insulate the program as best we can with its funding. We will have to have accountability at all levels, from the lead agency all the way down to the person taking in the referrals. But that's, that in my opinion is low-hanging fruit that can easily be done. As the state health officer, it is extremely important to me that the vulnerable populations are not only served, but served well. And that access in the Delta equals access in East Mississippi. And I do have heartburn in that area in terms of, who's going to take on the Delta, who's going to take on Southwest Mississippi, where there are larger challenges. But these are things that we can work through together. And what I pledge from the health department is we will plug holes everywhere we can if we're the lead agency. I'm going to tell you why. I'm going to finish up, tell you the story of why now I think it would be criminal to change the lead agency. I have been in the field. I spent about 30% of my time as state health officer in the field, visiting health departments, hospitals, wherever the crisis of the day may be. And I have had the opportunity to tour TK Martin when I visited Mississippi State, and I very recently was at USM's Child Development Center, and amazing resources for our state, amazing levels of expertise. While I was at USM, I had an opportunity to meet a granddaddy, and I've got my 4th grandchild is due today. But I had the opportunity to meet just a Lamar County granddaddy who was there watching his 3-year-old granddaughter with Down syndrome receive services. And we were watching her through the observation window. He was so proud. He was so proud of her accomplishments. He was so grateful to the services being provided to her. And right then, that connection, one granddaddy to another, we're gonna fix this. And we're not gonna abandon it. We're not gonna dump it. We're gonna apply our expertise and fix this with your help and your expertise. And then what we must do is make sure that the granddaddies in parts of our state who are worried about their little one, who's not receiving services, who needs our help, that we're able to get out there and plug those holes. I want all of our granddaddies of these special children to be proud and grateful. So this is it. If you can find another agency exec who's going to care more about this than me, then God bless you. Then they need to take it. But I'm taking this as a professional challenge. I'm taking it as a public health challenge. And it's one that all of us working together, we can accomplish. So I am today, Dr. Buttress, putting all the self-interest of the Mississippi State Department of Health on the table. No more territory, no more turf, no more power issues. We are putting aside our self-interest for the sake of this program. I'm praying that everyone on the task force will do likewise. Put our self-interest aside. What does the program need? What am I willing to give up for the sake of doing better for the children? What responsibility am I going to take on? You know, what cost am I willing to bear? I think the pay and chase model is really smart. And doctor to doctor, it would do my soul great good to be able to prove that state government could actually pay providers in a quick way instead of clogging up the system. That's another question we have to work through though. You know, pay and chase, there has to be a bank. How do we put money in the bank? But these are all answers we can work through together. I'm putting everything on the table except one thing. I will not run this program the way it has been designed and has since 2005 been operated. It is a system that is perfectly designed to give us the outcomes we're getting. So we have to change the system. We're ready to do it. Thank you.
Dr. Edney, thank you so much. And I know a lot of thought has gone into this. And as the chair of this task force, I think for all of our members, I'd like to tell you how much we appreciate your honesty and your ability to move forward on this. And Dr. Edney and I have talked about this, and I hope our task force members will agree, but if they don't, I'd love for you to speak out. I think it's time for us now. We've got a lot of public information. We know the opportunities that are there. I think instead of working more to gather more public comment, I'm not saying I don't want to receive it if people would like to send it, if it makes you feel better, but I think we know where the problems are. So what we need to do is, under the operation that we're supposed to be doing next, is to make some general recommendations on where to go next. Dr. Edney has laid out, I think, a good outline of, in general, where we may want to go. I do believe our next meeting probably needs to be dedicated, which is on September the 5th, dedicated to really getting down to the meats and bones of what we are supposed to do next. And we need to do it hand in hand. And I want to reiterate what Dr. Edney said. The only way we can be successful with this is to make certain that whatever we're pushing forward is not self-serving. We've got to do that. We've got to make certain that we are not pushing forward an agenda because it makes us shine, makes more money for us, or makes us look better for the kids. So I'll stop there. We have 6 minutes, and I'd like to hear from any member of our task force or advisory committee. If you have any thoughts or questions to Dr. Edney, please step forward. And if you would, I can't read the chat box, so just please unmute, if you will, and go ahead and say what you have to say.
There's a lot of people thanking Dr. Edney and applauding him for his personal and professional candor. I just want to say that we thank you for giving the attention to this that it deserves. I think most people on here would agree that this is a public health emergency. It's just been a long overlooked public health emergency for our young kids, and it finally feels like it's getting that attention now. So thank you for that.
Thank you, Dr. Walker. Anyone else? Well, with that.
So
Oh.
Susan, Dr. Buttress, I'm sorry. I think we need to look also at our percentage of services in the natural environment and see where we can partner to get these kids an early head start if we can partner to make sure that since the state defines what that goal should be, that we set ourselves a really challenging goal. So that people aren't having to travel multiple counties to get a service provider.
Right, and I think that's what Dr. Edney was referring to when he said that the services had become more centralized and there were 3 districts instead of the higher number, without me listing it because I might misquote. And so obviously, if services cannot be done in the natural environment, you certainly don't want a patient or a child and their parent traveling many miles to receive those. So we will be, Dr. Fitz, looking at that, and I hope you will help us look at that. I think our next step is to really roll our sleeves up, and we have the wonderful work of Emily Cloy and Mary Claire Ringer to help us through this. And I'm correct. We don't have to all write this. We will have the service of you guys helping us write this, but we, the task force, has to say what needs to be on paper. And so I really am very excited about Dr. Sutton and Ms. Adcock being with us. Know them both, and I know they're highly skilled and excited. So I hope, Dr. Edney, that they can join in as we are working on writing our recommendation.
Absolutely. We'll provide whatever resource needed.
Any other thoughts or comments from our task force? Okay, with that, I'd like to hear a motion to adjourn. Do I have a motion to adjourn?
I have a motion to adjourn, Dr. Buttress.
Okay, thank
Dr.
you.
Fitz.
I think I think everyone will second, right? Will somebody just raise their hand real quick?
Second.
Dr. Walker, okay, thank you so much for your time. Again, thank you, Dr. Edney.
Thank you.
For your effort. I know you're working very hard and doing a lot of hard work, so thank you. We appreciate it.
Bye. Thank you.